years. During medical school, she did research at the University of Calgary, and then was accepted here and is a chief in our general surgery residency this year. Starting in July, she has been accepted for a colorectal fellowship at the Mayo Clinic in Rochester. Dr. Martinez.
Good morning. The topic I'm going to present is colorectal cancer and metastatic disease. I'm going to start doing a little overview of the colon itself and colon cancer, and then we'll get into the depth of metastatic disease as well. Colon and rectum embryology. I mentioned it because it's a very common question in the ABSITE. The colon and rectum are derived from endoderm, and it begins to form approximately at 3 to 4 weeks of gestation. It comes from two different parts, the midgut and the hindgut. The midgut gives off the small bowel distal to the ampulla of Vater, as well as the cecum, appendix, ascending colon, and proximal half to 2/3 of the transverse colon. All of this receives blood supply from the SMA. The hindgut is the distal third of the transverse colon, descending sigmoid, rectum, and upper portion of the anal canal, of which receives their blood supply from the IMA. On average, the colon is approximately 150 centimeters in length, and it has unique characteristics that differentiate it from the rest of the bowel, which include presence of Taenia coli, ostras, and appendices epiploic. It has 4 layers like the rest of the bowel does, which includes mucosa, submucosa muscularis, and serosa. Here you can see the different parts of the bowel as well as the different vessels that provide blood supply to the colon. Let's talk about now colorectal cancer. Colorectal cancer is the 4th most common malignancy in the United States, and it's the 2nd most common cause of cancer-related deaths. However, if diagnosed early, colorectal cancer is actually one of the most curable malignancies. Mutations in 3 different types of genes contribute to the formation of colorectal cancer, and these include tumor suppressor genes, oncogenes, and DNA mismatch repair genes. There are different types, but we're going to focus on adenocarcinoma since this constitutes 90 to 95% of cases. Most of these are moderately to well differentiated, 20% are poorly differentiated, and these have poor prognosis. Other characteristics that are associated to poor prognosis include if they are mucinous, if they have lymphovascular invasion, absence of lymphocytic response to the tumor, among other things. This is mostly for our medical students, the TNM classification of cancer of the colon, T for tumor size, N for nodes, and M for metastatic disease. Based on this, then, it's divided in staging, being a stage 1, a T1 and T2 lesion with no nodes, stage 2, T3 and T4 lesion with no nodes, stage 3 as soon as you have nodes, and then stage 4 metastatic disease. What is important about colorectal cancer is really that surgical resection is pretty much the only chance for cure that our patients have. As you can see here, the 5-year survival, of course, starts pretty good at stage 1 with 93%, and then continues to decrease until you reach stage 4, which is metastatic disease at 20 to 30%. There's a specific surgical oncologic principles that we have to be aware of every time we talk about colorectal cancer. First, the knowledge of the anatomy is very, very important because that determines what you're going to resect depending on where the tumor is located. Always when you're going to operate, you operate with curative intent every time it's possible. Margins of resection are extremely important. It is, a distal margin has to be of at least 2 centimeters, and proximal margin generally we try to achieve 5 centimeters in the case of colon. And always, of course, consider doing the total mesorectal excision, which is the standard of care for rectal cancer. Regional lymph node dissection is also important to the point that a minimum of 12 lymph nodes is considered actually a mark of quality for our specimen. In the case of local recurrence, you should consider surgery plus minus radiation in order to allow salvage. There's also palliation in the case of locally advanced unresectable lesions, with the only goal in this case of relieving obstruction or pain. In the case of the presence of metastatic disease, surgical resection of limited metastatic disease can have actually a potential cure of the patient. Per the national guidelines from not only the NCCN but also the American Society of Colorectal Surgeons, they emphasize that appropriate surgical management of locally advanced colorectal cancer should include multivisceral resection. Of course, you always have to think of risk versus benefits, which are patient-dependent. Let's talk about the management of these real quick. If you have a colon cancer, not rectal, but colon cancer, stage 1 and stage 2 disease, first, stage 1, T1, T2, and 0, it's pretty much after resection is observation. There's no need for adjuvant therapy. These are the last guidelines published by the NCCN in this year. And as you can see, this is different. If you have a T3N0, M0 with no high-risk features, you have the option of either observing or giving chemotherapy in the form of 5-FU and leucovorin, or capecitabine, most commonly 5-FU and leucovorin. And if you have a T3N0 with high-risk features or a T4, then they recommend for you to give FOLFOX, which is 5-fluorescent leucovorin, and then you add oxaliplatin to that, which is the most common. Or you can also give capecitabine and oxaliplatin. In the case of stage 3 disease, which is when you have nodes, the standard of care is FOLFOX. Adjuvant chemotherapy is associated with a 30% relative reduction in recurrence and a 22 to 32 reduction in mortality, which is why it's so important to give. When we go to colorectal cancer stage 4, in the United States, approximately 20% of patients actually present with metastatic disease on diagnosis. Surgery is the only thing that can actually provide a potential for cure in this type of patients, as long as they have limited metastatic disease. If you do an aggressive management combining chemotherapy and surgery, long-term survival in these patients can be as high as 50% at 5 years. So when you have a patient that has metastatic disease, you have to start thinking this way. Well, is this metastatic disease resectable or unresectable? And if it is unresectable, can it be potentially convertible to being resectable, or it's unconvertible? Because this will guide your treatment and management of the patient. Let's say it is resectable. So if you have resectable, synchronous liver and or lung metastases only, these are your different options that you can do for management of the patients. You can do a colectomy plus synchronous or staged liver or lung resection of the metastatic lesion, followed by chemotherapy, or you can give neoadjuvant chemotherapy followed by synchronous or staged colectomy, as well as resection of the metastatic disease, or you could do the colectomy followed by the chemotherapy and stage resection of the metastatic disease. The preferred way to go is colectomy plus synchronous or staged liver and lung resection followed by chemo, as long as it is a resectable lesion and the morbidity associated to it, depending on the patient's characteristics, is appropriate. Otherwise, you would do the neoadjuvant pathway. So that's why I mentioned things to think about. Resecting the primary is, of course, not without risk. There's a 20 or 30% risk of morbidity associated with it, as well as a 1 to 6% risk of preoperative mortality. You have to have this in mind, because if there are complications postoperatively, this will delay the patient receiving chemo after this. Available data, though, does suggest that in patients who present with metastatic colorectal cancer, as long as they have an asymptomatic primary, if you manage these initially without resection, the risk of them bleeding is actually not that high, it's 3%, and the risk of perforation or obstruction is 7 to 14%. If you go the other pathway, if you find an unresectable synchronous liver and or lung metastatic lesion only, then here it's recommended to give treatment with chemotherapy. For the most part, the standard of care is FOLFOX. But you also can give other things like fulvophrori or capioxa is actually capecitabine and oxaliplatin plus bevacizumab. In this case, if you have an unresectable synchronous metastatic lesion, you should consider colon resection only if the patient is obstructed or bleeding. Once you start treatment, you should reevaluate for conversion every 2 months to see if they become resectable. And if they do, then you would go back to the same pathway that I previously mentioned of doing either a synchronized or staged resection of the metastatic lesion followed by chemotherapy. Here you can see a CT of a patient that was first deemed unresectable, and then after conversion therapy, this was significantly reduced in size and now became resectable. So in this case, they switched pathways. In the case of rectal cancer, things are a little different. Stage 1 is still excision. For stage 2 and 3, what is recommended right now is neoadjuvant chemo and radiation, followed by surgical resection and adjuvant chemotherapy. In the case of stage 4, if you find metastatic disease, again, you go to the pathway of resectable or unresectable. If it's resectable, you do the same, chemo radiation first, followed by surgery, followed by chemotherapy. If it's unresectable, however, then you go if it's symptomatic or not. If it's asymptomatic, then you do chemotherapy only. If it's symptomatic, then there's multiple options that you can do depending on what the symptom is. And I'll talk in more detail about these later, but they do include stenting, formaldehyde ablation, laser ablation, etc. This is just an example of a metastatic lesion in the liver, a laparotomy. Let's talk about resection of this metastatic liver lesions. The 5-year survival after you resect a liver lesion is been explained or described from 24 all the way up to 58%, averaging 40%, with a surgical mortality that's relatively low at less than 5%. This is very significant when you compare these same patients that only receive chemo and their 5-year survival is barely 10%. So this difference in survival is very significant when you actually can resect the lesion. Approximately a third of the 5-year survivors that suffer a cancer-related death, while those that survive 10 years, once you've survived 10 years, pretty much you can be considered to have been cured of your disease. Because of this clear survival impact is that surgical resection is a treatment of choice when it's feasible. Unfortunately, less than 20% of patients that are found to have metastatic disease to the liver are actually resectable. The criteria to do resection of the liver of the metastatic lesions vary among centers, but for the most part, as long as you don't have radiographic evidence of major vessel or bile duct involvement, no distal lymph nodes like periaortic or celiac axis lymph nodes, if you have adequate hepatic reserve, as well as no unresectable extrahepatic sites of disease, you should be okay. For the most part, these are the indications. There is a group of conventional indications, and then more high-volume centers have more modern aggressive approach towards these metastatic lesions. In the case, for example, if they ask us something in the boards, most likely, if we stick to the conventional indications, it would be mostly accepted for us to answer. These include if you have less than 4 mets and they're unilobar, that should be okay. If the mass is less than 5 centimeters, you have to have a margin of at least 1 centimeter, no extrahepatic disease. You have to have, of course, an adequate liver remnant after resection. You have to be able to resect all the macroscopic disease present. There has to be no invasion of the vena cava or hepatic veins, as well as no portal lymph nodes. This can be stretched to really no limit in the number of mets or the amount of lobes involved, no limits in the size of the mets. The margin can be less than 1 centimeter because you can always do local treatment to this afterwards, which includes either RFA or chemotherapy embolization, etc. So there are other options even if you have a positive margin. In the case of extrahepatic disease, as long as you have pulmonary disease that is also deemed resectable, then it's also okay. In the case of you not having an adequate liver remnant, there are cases of the portal vein or the vessels that go to the specific area of the tumor being embolized to try to induce hypertrophy of the liver remnant. And then again, even if you can't resect all the macroscopic disease, there's other local therapies that you can do that can still encourage you to do the resection. In the case of the invasion of the cave and hepatic veins, some centers consider this even not a contraindication as long as you can do a reconstruction. And same thing with the lymph nodes. Surgical technique to do the removal of these liver lesions, there's several described, of course. They're all patient-dependent, also surgeon-dependent, which include open, laparoscopic, or hand-assisted laparoscopic. However, there are certain things that you should do, regardless of the technique that you utilize, which includes a full abdominal exploration to exclude any extrahepatic disease. This includes any suspicious lymph nodes that you find. You should biopsy and send for frozen because that can change your plan. The liver should be inspected and palpated if you can, if you're doing a hand-assisted technique or an open, as well as fully mobilized to make sure that you don't miss any other lesions that the imaging did not catch. And the other thing you should do is an intraoperative ultrasound for the same reasons. The intraoperative ultrasound will also guide you in regards to your resection because you will see if there's any major blood vessels by the area that you're going to resect. So the intraoperative ultrasound is important because it can maximize your chance of obtaining a negative margin. There are different ways you can do it. You can do anatomic resections or non-anatomic resections. Especially in the non-anatomic resections, the intraoperative ultrasound is especially important because it keeps you away from big structures that can get you in trouble. In the case of doing an anatomic resection, inflow and outward control are key. In regards to techniques of parenchymal transection, there's multiple techniques that you can utilize, which include finger fracture, ultrasonic dissector, water jet dissector, saline linked radiofrequency dissecting sealer, bipolar, harmonic, stapler devices, etc. Depending on where the lesion is, there's different resections that you can do. These are more or less the anatomic resections. So if you do a right hepatectomy, you would remove segments 5, 6, 7, and 8. A left, it would be 2, 3, and 4, plus minus 1. And then when you go to the true segmentectomies, it's pretty much as an extended right or an extended left hepatectomy. And then the left lateral resection, which is segments 2 and 3. So this is where you would see here. This if you do the resection of the left lateral segment, which is 2 and 3. Then if you follow Cantor's line here to do the right lobectomy versus left lobectomy, and then right trisegmentectomy when you extend to include segment 4, or vice versa, left when you extend to include segments 5 and 8. You can also do local resections, which are called segmentectomies. So as you can see here, you have a segmentectomy of segment 6, and then you use the intraoperative ultrasound to find these vessels to try to stay away from bleeding. Again, you can even do a segmentectomy of segment 8 up here. And then you can also include multiple segments. The objective of doing this is, as long as you have a greater than 1 centimeter margin, you should try to preserve as much liver parenchyma as possible. Now let's talk about unresectable hepatic metastases, like this CT scan right here. In the case of unresectable hepatic metastases, systemic chemotherapy is the way to go. Now, there's 2 different pathways you can take, even with chemotherapy. One is conversion therapy, and one is palliative. And this is depending upon the fact if you think that the patient can convert from being unresectable to resectable. If you think he can, then you give conversion, which is a more aggressive type of chemotherapy versus palliative. The main difference pretty much is including a biologic. Biologic includes either monoclonal antibodies against vascular endothelial growth factor or monoclonal antibodies against epidermal growth factor. Another thing that comes into account is the situation of the patient. Will they even tolerate a more aggressive chemotherapy regimen? There are other options which include regional chemotherapy via hepatic artery. There's also selective internal radiation using yttrium-labeled gas or resin microspheres. And there's regional tumor ablation, like I had mentioned earlier, which you can do either with hyperthermic or radiofrequency coagulation. You can do also intratumoral injection of ethanol, acetic acid, or cryotherapy. The most common ones that you utilize right now is radiofrequency coagulation. Let's talk now about pulmonary metastases. As you can see here. In regards to pulmonary metastases, there's really no randomized trials at all evaluating the benefit of resection of pulmonary metastases. The ones that exist are not limited to colorectal cancer, but to any metastatic disease to the lung. In 1991, what they did was the International Registry of Lung Metastases was created, but this, like I said, includes every sort of metastatic disease to the lung, not only colon. They made a report in 1997 that included 5,206 patients that showed an overall 5 to 10 year survival rate after pulmonary metastasectomy of 36-26% respectively. And based on this, they started thinking, well, maybe we should resect the pulmonary metastases too. There are factors that are associated with better prognosis if you do, which is, of course, if you do a complete resection of the metastatic lesion, if it's single, preferably, and limited to a specific segment or lobe, and if it's the only area of metastatic disease, and if the longer the disease-free interval between the treatment of the primary and the diagnosis of a pulmonary met, the better. As long as it's greater than 36 months, it actually is worth to go take out the metastatic disease in the lung. The criteria, there aren't really no published criteria, but these are more or less the criteria by which most centers go with, which is you have to make sure that the lesion is going to be completely resectable, at least by imaging. You have to make sure the patient, of course, has adequate pulmonary reserve, cardiopulmonary reserve after you do your resection, that it's technically feasible, that there are no other sites of metastases, and you are able to control the primary site. And if they do have extrapulmonary metastases, that this is also controllable. So this is just an example. Depending on where the lesion is located, of course, is going to determine what procedure or technique you do. In this day and age, you can do a thoracotomy or you can do a VATS, which is the video-assisted thoracoscopic surgery. There are certain things that you have to take into consideration when you do this, and is that the staging is pretty much the same that when you are treating lung cancer. So even if you deem the patient to be resectable and you take him to the operating room, you should do a mediastinoscopy. Because if they have N2 disease, which is positive nodes in their mediastinum, then you should not do the resection. There are other sites of metastases which are rare. Adrenal is one of the more rare ones. You can also have ovarian, which is present in 1 to 14% of patients. Brain metastases, 1 to 4%, and bone metastases, 7 to 9%. However, all of these most commonly present in the setting of widespread metastatic disease, not as isolated metastases. Now let's go to metastatic disease, but in the form of peritoneal carcinomatosis. In this case, we go more with what we define as salvage options once you have peritoneal carcinomatosis. What is really big right now is doing the hyperthermic intraperitoneal chemotherapy, which you give at 42 degrees Celsius, associated with mitomycin C and cytoreductive surgery for peritoneal carcinomatosis. Cytoreductive surgery pretty much means that you resect everything that you can possibly see that has tumor involvement. There are 2 randomized trials that talk about this. There are several retrospective case series and some systematic reviews. I just put a little bit of a review of what more or less all of them say, and it's that disease-specific survival was improved to 22 months versus 13 months, and 45% survival at 8 years when you do this type of procedure. However, it is not considered a standard of care, and there are not true randomized control trials about this, because even the 2 that they did For some reason, the type of chemotherapy they used was 5-fluorouracil leucovorin only, which is not the standard of care for metastatic disease because it should include at least oxaliplatin plus minus a biologic. So they didn't give him the best possible chemotherapy regimen, so to speak, to be able to be comparable to this procedure. So unless they do something like that, that would really tell you if there is a difference between doing such an invasive procedure versus giving the best chemotherapy possible. Other options do include intraoperative electron beam radiation. As part of the salvage procedures, there's also exenturative procedures, which is a total pelvic exenteration, which involves the removal of the rectum, the anus, the ureters, the bladder, pretty much everything that is within the pelvis. In extreme cases, even the sacrum and the coccyx. This, however, does have a very high morbidity and mortality associated to it, with substantial negative impact in the quality of life of the patient. Palliative options are also considered. One of them includes bypass procedures when the primary is surgically unresectable and they are obstructed. You can also divert them, which is somewhat less invasive. And, of course, the placement of intraluminal self-expanding metal stents. This is becoming more of an option now because the patients have a shorter hospital stay, it's significantly less invasive, they have a very short recovery, so you can start chemotherapy earlier. However, of course, like everything, they also have complications, which include stent migration, perforation, or even obstruction. Other forms of palliative options include formaldehyde sclerosing for persistent local recurrence. This at least keeps the patient from bleeding as well as from getting obstructed. And local tumor ablation, where you can use, for example, argon ion. This is actually pretty effective. It restores luminal patency in approximately 88 to 97% of patients that have obstructive symptoms but not a complete obstruction. However, it does require multiple sessions, and the more you do it, the higher the risk of perforation. In regards to chemotherapy for stage 4 colorectal cancer, I kind of talked about it a little bit already. There are 5 major classes of drugs. The fluoropyrimidines are kind of the standard of care, which includes the 5-fluorouracil, which is usually given with leucovorin. There are other options, but generally that's the one they use it with. There's also irinotecan, oxaliplatin, and then the 2 biologics that includes cetuximab, which is a monoclonal antibody against epidermal growth factor receptor, and bevacizumab, which is a monoclonal antibody against vascular endothelial growth factor. So here you have the options. You have the neoadjuvant intense therapy, which for the most part, the standard of care is FOLFOX, which is 5-fluorouracil leucovorin oxaliplatin. And then you have the conversion therapy, which you give to patients that you think that can potentially go from having unresectable metastatic disease to resectable metastatic disease. And in this case, you use pretty much the same ones, the FOLFOX, FOLFOX0, FOLFORI, and then you add a biologic. In these cases, in the patients that you give conversion therapy, 12 to 33% of these patients have actually a sufficient objective response to permit subsequent complete resection. And what's so important is that the 5-year survival of these patients is as high as 30 to 35% compared to 4 to 9% if you only give them chemo. Like I mentioned, FOLFOX and FOLFIRI have similar first-line efficacy, so the decision to give one versus the other is mostly dependent on the patient and the toxicity. Even with the most effective regimens, the complete pathologic response of these lesions, though, after neoadjuvant chemo is only 4 to 9%. And even if in the imaging it looks like the tumor has gone away, so to speak, there is still viable tumor there, so a resection is still indicated. So in summary, in the case of colorectal cancer, local control is pretty much key from the beginning. not only of the primary site, but also of the metastatic site, if this is an option, since this is the only chance for cure that the patient is going to have. In the case of local recurrence, you should try to reach multivisceral resection or enter to procedures for salvage if indicated. Metastatic disease, again, try to resect if feasible and safe for the patient, of course. And then there are other options like chemotherapy, radiation, as well as salvage and palliative options for patients that are unresectable. Thank you.
Kind of an important topic where technology over the past 40 years has made a big difference with flexible endoscopy, and I can't believe that we ever practiced medicine without CT scans. And I think that's where our liver resections failed. Now with the 3-phase, it really gives you a great picture. And the other thing that always amazed me about this is the variability in the biology of the tumors or in how the patient responds to it. Because we've seen people who we've resected and all of a sudden they're dead in 3 months. Then we've seen people with residual disease just seem to keep on chugging along and doing okay. So I think there's a lot to be learned about the biology of the tumors. Yeah.
And that is still kind of in the works. There's multiple studies that are trying to find biologic markers in the tumor themselves that should guide treatment so that you should be more or less aggressive from the beginning with chemotherapy. And it'll also guide the type of, like the specific drugs that you would give, being some more effective than others. However, as of right now, that is still very, very expensive, so it hasn't become a standard of care, but I think with time it will.
Dr. Cruz.
Excellent presentation. That was very nice. I just want to make a comment about benchmark lymph node dissection. It really took over half a century for this to be established. Because in the late 50s, when we started doing second look, we discovered that the most common site of, let's say, in the distal colon of recurrence was the highest lymph node along the inferior mesenteric artery, beyond it at the level of the fourth portion of the duodenum. And same wise with the transverse colon going into the celiac axis. And so I think that it's worthwhile to note that indeed with increased number of resection, you can convert the patient to cure, which you usually don't do it in breast cancer patients, for example. And the other thing also is that when you do liver resection, at the time of initial resection, 20 or 30% of the disease of the patients have extrahepatic disease. And you've got to be aware of that. And the other thing, lastly, about chemotherapy, is that if you have marginally resectable disease at the onset, be patient. Give as much chemotherapy as you can. Don't be afraid of the delay, because extra delay is probably going to mean plus for the patient in marginally resectable patients. Again, I enjoyed your presentation.
Tony, we've seen response to the metastatic disease with chemotherapy in those stage 4 patients, but I've also seen the primary grow.
Well, that's true. That's why you have.
And then somebody has to look in.
Right. Okay. You completed it. I think that if you're going to do that, as Dr. Martinez said, you have to evaluate the patient every 2-3 months at the most.
Or in Dr. Ramos, multi-specialty involvement.
What he mentioned is so important, because now if your specimen doesn't have at least 12 lymph nodes, it's actually considered and treated like if it was no positive disease.
And our pathologists know that they're going to keep on dissecting until
Yeah, get the pathology.
Dr. Schlesinger.
Very nice presentation. You've kind of outlined the ideal, and the protocols you suggested are the ones that give the best results. The unspoken facts, though, are that there's a socioeconomic issue as well. And while you've identified chemotherapy and X-ray therapy as important portions of the protocol, not everybody can afford that. And nationwide, internationally, and even locally, the socioeconomic issues play as important a role in determining how we treat people and how well they do. Did you come across any information that kind of separates that factor out? Because it's an important one.
But that's, I mean, we experience, I mean, when I was in your service, we experienced that every day, how unfortunately our management sometimes has to be changed by the fact that, you know, the patient's going to go out and not have insurance and not get chemo and just get lost, unfortunately. But yeah, in none of the papers that I read, they mentioned that.
Dr. Ramos.
Yeah. Extremely well done.
Thank you, sir.
The factors, the socioeconomic factors are very, very relevant because we should look at the other area. The other area is early detection and prevention.
Right.
Early detection and prevention will really help on decreasing the number of deaths by colon cancer. And recently, last week, colonoscopy paper says that doing screening colonoscopy and harvesting the polyps will decrease the mortality of colon cancer.
Right.
And that is a significant progress on saying that. Because now we can tell to the people, shift your emphasis not to discover 2008 drugs
Right.
at the end of life, but shift your
Prevention or early
to prevention and early detection.
detection.
So, in South Texas, Mexican Americans use colonoscopy, screening colonoscopy, 30% less than the rest of the country. So we need to find ways of increasing that number.
True.
Dr.
I
Pasad.
have a suggestion for increasing those numbers. Find a way to do a colonoscopy without the bowel. You can do that. I'll be the first in line for my colonoscopy. I took the last one and the first one from the
I was just thinking you were going to say put a breakfast taco on the end of it. But
bring it into the office first.
So, Maria, good overview. And some of the questions I'm about to ask you kind of alluded to, but I'd like to hear them very, very specifically and very clearly. First question is, you mentioned stents as an option, but not in a specific case scenario. When should we stent? If somebody comes in to the emergency room or to clinic looking like maybe they should have gone to the emergency room, when should you stent is the first question.
Pretty much the kind of classic scenario would be if you have a patient that is not obstructed yet, because obviously you have to be able to pass, a wire or something to be able to put your stent, but with obstructive symptoms and what is deemed as unresectable disease at the time. So you're trying to bridge him to give him chemotherapy first, to try to see if you can make him resectable later. So you would try to stent that patient, especially if it's rectal cancer.
Yeah. The other part of this question that's not there is, are you going to stent somebody that doesn't have metastatic disease so that you can do a more elective operation?
For rectal cancer, yes. If you as long as you can technically reach it, because you can't do really
You cannot do right.
Right, you can't or transverse. So rectal and sigmoid, yes.
So even if they don't have stage 4 disease, but they're almost obstructed, so that we don't do the old colostomy.
No,
and then
right.
come
And
back.
you can do an actual an appropriate workup, because we're talking about the one that comes in the ER, right?
Mm-hmm.
So he needs a full work. I mean, he needs metastatic workup, he needs CEA, he needs bowel prep, he needs to just to try to make your conditions as optimal as possible for his, try to make his surgery an elective procedure.
Dr. Dent.
Somebody who's obstructed.
That's why you stent him. That's what I'm saying. You stent, after you stent.
But, so, how strong is the data on that? Because the data I've seen is mixed at best.
It's mixed.
And such that you can't say it's better care is the conclusion I've reached. It's a good option.
Right.
I'm not saying it's bad care, but I haven't seen data that says that's
It's not,
really the best way to go
no,
yet.
there's no data that
Kellenberg
say,
had data from here, and I don't remember the number of patients, but it was around 50 maybe. Huh?
What he's looking for is controlled data, and that wasn't from here. It was just a retrospective.
most of the studies,
It's an ethical problem.
right.
It's an ethical problem. How are you going to...
You can't really randomize, exactly.
Right.
Right, you can't really randomize that.
And take your pick.
So it's like that. It's just retrospective reviews to see how it worked. It's not a standard of care at all. No, it's just an option. That's how it's mentioned. I'm sorry.
And then in terms of the patient who presents initially with metastatic disease, let's say transverse or right colon, deciding whether to do the colectomy or just start chemo.
Mm-hmm.
Okay, if I heard you correctly, if they have any obstructive symptoms, go do colon surgery.
Yes.
Early on.
Mm-hmm.
Okay. If they don't, then there's about a 3% chance they'll present bleeding if you don't do the colon at that time, and
Yes.
about a 8 to 15% chance they'll present
That they
with
will obstruct.
obstruction.
Yes.
Okay, and so how do you decide? You just explain that to the patient and the chemotherapy doctors and say there's a 1 in 7 chance you're going to need an emergency operation in the middle of chemo?
You explained that, but there's several things that you have to explain. First of all, you have to see if the metastatic disease is resectable or not. If the metastatic disease is resectable and the patient is physically, just medically and physically fit to undergo the colectomy and the resection of the metastatic disease, then that's what you should do. However, if the patient is not medically fit to undergo both things, hepatectomy plus colon resection, and he's not obstructed or bleeding at the time, then you give chemotherapy first, with the understanding that he could have one of those two options.
If it's stage 4 and it's rectal cancer, they won't give radiation. They'll give just chemotherapy because they can give a higher dose of the chemotherapy, is what I've gleaned from the tumor board recently.
Correct. But then again, as we talked about before, you really have to follow the patient closely.
Right.
But the thing is, if it is questionable that you're able to do that, then you have to, I think what you're alluding to is just go ahead and operate on the patient.
Right.
And there's nothing wrong with that because that's pretty much probably what's going on.
Yeah, well, no, the thing I've wondered over the years is I've seen patients like that started on chemotherapy, the ones with unresectable metastatic disease, and asymptomatic colon primary, but clearly present colon primary. And I've seen them fail and become obstructed in the middle of chemotherapy when their white blood count is 0.00 something. And it's a disaster. And so I've seen people then conclude that you should never do that based on that one case. And I'm not seeing great data that gave you the odds. And I think it's reasonable what you're suggesting to look at, and I just explain to the chemotherapy doctors and your patient, there's a 15% chance you're going to need an emergency colon operation in the middle of chemotherapy, but 85% or so chance that we'll do the chemotherapy and then come back and reassess. Is that a fair way to phrase it?
Now, there's also the option of that you could do the colon resection and a staged metastatic resection. You don't have to take both at the same time. You don't
That's
have
if they have resectable disease.
Right.
Right. No, but if they have resectable disease, you're doing colon surgery at least.
Yes.
Yeah. I'm talking about if they have unresectable disease that might become resectable with chemo.
Right.
Dr. Ramos.
The key word is symptoms. Symptoms or no symptoms.
Right.
And that depends of your perception on the history tape. I have seen some tumor-borne cases presented with clear symptoms of obstruction And because there is no X-ray findings of
That show
amount of
obstruction.
gas and everything that they go by, again, cultural problems, understanding the small changes. And they say it's not obstructed, just to show up the next week with complete obstruction. And the colon is particularly good at that because the colon gets into complete obstruction at the very end.
Right.
When there is 3 millimeters of lumen, you still have a bowel liquid and so forth. Oh, it's not obstructed, it's passing gas. It's passing. Yeah, but it's just 3 millimeters, and then something plugs those 3 millimeters and they become obstructed. So I would rather go into and operate those patients early than wait until they have the avastin with the
Right.
metastasis.
Mm-hmm.
If there are small lesions, then they can
Right.
get chemotherapy.
Garbagili.
Maria, again, this is a nice talk. Let's go back to the liver a little bit. I have a couple of questions. You're talking about reserve.
Yeah.
And you touch on this. You said embolization, atrophy, hypertrophy. You embolize the portal vein, give the diseased lobe to shrink, and the normal lobes, then they can resect. How about infusing interleukin 6 like the Japanese do into the portal vein? It's a growth factor, and that will help hypertrophy of the liver, and you'll have more reserve to do. Have you encountered in your research?
Not for liver meds.
Not for to enlarge the liver, to allow you to do.
But not for specifically, I didn't encounter it in the situation of colorectal metastases.
Okay. The next question is, let's say you have more than one metastasis, multiple. They get chemo, and oxaliplatinum is very, very effective. It melts. Well, what are you going to do with those multiple metastases all over the place? Are you still going to chase them? Are you just going to wait? You're going to give them, wait, finish. What are you going to do with?
So it kind of depends on if you do resect what you would have left, pretty much. Because, like I mentioned, some say that if you have a complete pathologic response, you can watch them if the morbidity of doing the surgery is going to be too much for the patient. However, if you have, 5 lesions and they're limited to one lobe and the patient can undergo the hepatectomy, then you should do that.
Somebody with the oxaloplatinum liver? The blue liver? Have you ever seen it?
No. And that also comes into account many times. They're saying that the people that are trying to promote the resection of the metastatic disease from the beginning, they use that to back them up. The fact that oxaliplatin, which is such a great drug to kill the cancer per se, also kills the liver. So if you can resect it before giving oxaliplatin is better. Mm-hmm.
Yeah, I was just going to say, chasing multiple meds, I couldn't do myself to push myself to do that. But I had a colleague, the late John Stephen Minton. You heard his talk about this. He chased those.
I did it with him.
Oh, okay. You did it for him.
Swiss cheese.
Okay, and then it ended up like just a Swiss cheese, Every time he cut out one, he plugged a wad of 5-fluorouracil and said, that should take care of that. And he had some long-term survivals on that.
Well, the bogey at 100 was early radiofrequency ablation.
The first version.
But Tony, we had Mary Pat Moyer, our cell biologist, microbiologist, on the faculty, and she was the first one to grow both gastric and colon epithelial cells in culture, and then also cancer cells from both the stomach and the colon. And we knew that gastrin was a stimulant for growth, and it stimulates the growth of both gastric and colon mucosal cells along with the cancers. But one of the things that did come up is that the primary acted differently than metastatic implants. I mean, do we see that clinically, or is there any basic research? I mean, this is something that came up 20-some years ago. in our experiments, and I've never seen anybody really talk about it, that the two behave differently. They're sometimes different biologic entities. Or maybe that's why we see the primary grow and the liver melt.
Well, I think that probably was an observation that was made by Mary Pat Moyer with no particular regard to differential responses. Like we have targeted therapy now that more specific than that you probably could look at it as non-specific before, but as of now, you do have better means of differentiating different tumor cells.
Does patients who have 2A lesions, they don't get chemotherapy based on what you presented and based on what we see from the tumor board, but we've had patients come back with disease. Is there
2A gets chemo now. 2A chemo gets chemo now. It's a new guideline.
I'm sorry,
it's a new guideline.
I'm sorry.
It didn't used to, but now it does.
Okay. Dr. Dan?
So if you have 3 or 4 metastatic lesions in the right lobe and 2 or 3 in the left lobe, you do chemo, and at the end of that, you've got a single lesion in the right lobe that's 2 to 3 centimeters. Do you resect that right lobe, or do you assume those left lobe lesions are still present in a microscopic basis and you don't resect?
That's a good question.
Okay.
Probably I would go with, because what at least per what I read, even if you have a complete response in imaging, that does not mean it's a true complete response. So I wouldn't go just searching for that one that's there when potentially I'm going to leave the rest behind. So you would probably use chemo through embolization, RFA, all the local options.
Okay, because that's what has always troubled me when I think about these. No, he said he'd do RFA. But when I think about these, of taking unresectable to resectable, right. Yet at the same time, assuming that complete response does not mean there's no tumor in that area, they're a little contradictory right. In that scenario I just presented, and that's why I've had a hard time getting it in my head.
I think it'll be easier to determine if you resect or not if it's not bilobar, for example. Mm-hmm. So then you would, it would be a limited resection, would be one lobe versus both lobes. Can't really resect both lobes. So.
The 3-phase CT scans are helpful, especially when we're dealing with hepatocellular carcinoma, but they still have those small pockets that just aren't going to show up yet, and you're subjecting the patient to a huge whack. Perry, anything to add?
I think that's the changing paradigm is the chemotherapy, basically primary palliative chemotherapy for asymptomatic metastatic disease. The teaching used to be always take out the primary because it's going to obstruct or it's going to bleed. But I think we're starting to accumulate reasonable data that you have to operate a lot of people to prevent the complications. You're going to need to operate on 6 to 10 patients to prevent one complication. And so I think that's a real change in our way of looking at it. But I think Dr. Ramos's point is important, is that you really have to do a good history on these patients. Symptoms are short of complete obstruction. Now, if you have a patient that is symptomatic, then we're still going to recommend a resection up front. But if it's truly asymptomatic, widely metastatic patient, then palliative chemo without surgery is appropriate.
Rajesh had a question.
Dr. Sabu?
Oh, sorry.
I just wanted to mention, and
yes, ma'am.
Forgive me if you had mentioned this and I missed this, but one of the hottest topics in pathology and for this chemo for the earlier stages is genetic instability. And they're now sending this off to new tests, and also micrometastasis, and also sentinel lymph node for colorectal cancer. Sentinel lymph node because why would you do that? You're going to get 12 nodes anyway. Well, the reason is the one closest to the cancer, or the sentinel lymph node, done near the cancer, will be actually sectioned much finer than the rest of the lymph nodes to look for these micrometastases, which nobody's really sure what to do with it. And now it's becoming more routine. They ask for it in these earlier stage cancers to decide on the chemo with the 2A, et cetera, for the genetic instability. So it's not just a necessary blanket, because those studies are kind of still out. But especially you'll see that it's kind of a hot topic, the central lymph node in the literature. And when you go to these specialized centers, these are the things they're starting to look at. And one of the hottest topics is micrometastasis and instability locally. So, hi.
Hello?
That's something they're going to be sending off for routine studies now in these tests, and we need to be aware of that.
Yes.
You got a question over here? I'm sorry, I had my back to the right. Dr. Phillips, did you have a question? Go ahead.
No, sir. I was going to say that if I would, Dr. Dent's situation, I would resect. I mean, most people will resect if it's sub-centimeter and diffuse on the other side, and it's melted away. If it's greater than that, then they do an intraoperative ultrasound and RFA if there's any residual evidence in the contralateral liver.
All righty. Thank you very much.
Thank you. Thank you, sir.